massively need the microphones, but for our compact bijou Grand Round today. But anyway, welcome to Grand Rounds. My name's Tom Ford and I organise this shambles. So, welcome for those of you who have come, and we would be going to Perth, but that seems to have failed. But we do record the talks, so they're available to people online eventually when we get our online service back up and running, which I'm told is in the works. We will have all our talks online soon. This week, sharing the success of FY2. I don't know, I'm telling you, the people who are speaking are the people in the audience. And you know what it is because you've made the effort to come here. So it is sharing the success of our FY2 quality improvement projects. I think this is really important. I think this is, you guys beaver away doing these quality improvement projects. The e-portfolio say you must do a QIP, and some people pay it just lip service and do something, and you guys have done some really quality work, and I'm really looking forward to hearing what you've done, and I will try to get these things online quickly so that more people can know about it. But first, my friend and colleague Fiona Cameron is going to come and say a few words, and then I'll leave it to Vicky to orchestrate the rest of it whilst I have my sandwich.
Thanks, Tom. It is actually very hard for me to say a few words. I'm not usually short of words. Thank you very much to everyone for coming. The purpose of today is, as Tom has said, to share the successes of our FY2s in doing their quality improvement projects. I think for those of you who are not familiar with the Foundation programme, QI is a really fundamental part of their training now, and it's really taken over audit, which we had in the past. It is mandatory. They have to do QI. They have to show evidence of engagement in QI. And it's something that we value in Foundation as educators, and also the service really values, because these guys are the ones that are actually working, grafting at the coalface, and they can see where things need to be done. And, there's lots of them. So, those of you who are here from the wards, they're a very valuable resource. Just to let you know, the ones in FY1 have to show some engagement in QI, and that is something like reporting on a DTEX, reflecting on a DTEX, but in FY2 we actually expect that they do a QI project, whether that's part of somebody else's QI project, a collaborative effort, or whether that is done on their own, and they have to write in the report, and then they have to get that assessed at ARCP. So I can't deliver all of this. The person who has absolutely been a huge star in all of this is Vicky, and Vicky's got a couple of slides just to remind everyone what her role is within QI and where it's going, because she's done a vast amount of work, and she's the one that supported all the trainees here.
Okay, thank you. Just very quickly wanted to show you a couple of slides. We have a 2-year programme for our FYs in quality and safety, and the first year really very much focuses on safety, and Fiona mentioned one of the key activities is trying to create a culture of reporting with our FYs. But the second year is very much round about carrying out a QI piece of work, and what we're trying to do this year is link to the department's sort of key priorities, rather than people doing individual pieces of work, trying to link into what your department actually needs. It's a supported programme. Some FYs take up the support, some don't. We have QI coaches across NHS Tayside who can support with the day-to-day understanding of QI. There's a whole programme there, and we link in with the Institute of Healthcare Improvement as well if the FYs want some kind of certification for what they're actually doing. What I'll do now is hand you over, and the first person who's going to speak is Matt Playfair, so he will give you a bit of an overview of his piece of work. Thank you.
What I didn't say is we're voting, and there's a prize for them. Okay.
So you have to vote
Some
at the end.
people get a prize.
Yeah.
I've just had an email to say that the people in Perth can see and hear everything. We just can't see them. So there is an audience, there are people in Perth, the numbers are slow.
Imaginary people.
It's all good.
All right, perfect. Well, I'm Matt. This was a quality improvement project I did during my time in orthopedics. The goal of it is we were looking at how post-operative notes were handled once the patient was out of theatre and back on the ward, and whether or not they were being followed up by the FYs on the ward, and whether or not the tasks associated with them were being done or not. Post-operative notes are important. Junior doctors should know about them. But the real problem we found was with patients and their post-operative notes, and as to whose role it would be to follow them up. orthopedics, it's somewhat unique because you have a trauma meeting at the beginning of the day where all the patients who have surgery on the trauma list are identified, and where they are in the orthopedics department is identified. Then magic happens. They either go to surgery, they get canceled, they get delayed, something occurs, and then more magic happens, and then they show up on a ward. Sometimes it's the ward they were on before, sometimes it's not. No one knows, no one tells you, and then they have a post-operative note. So part of the problem here was a lot of uncertainty as to whose job it would be to chase that note. If you're in charge of one ward and a patient's on your ward at the beginning of the day and isn't at the end of the day, and their post-operative note hasn't been chased, is it your role to find that person and chase it up, or should the person whose ward they went to do it? And a lot of things were being missed. So part of the problems with this is if you don't look at a post-operative note, the patient's had surgery, the surgeon's taken an effort in writing some things down that they would like done. Some of them are quite urgent. So please transfuse 2 units of blood for this patient would be a fairly urgent thing you might write on a post-operative note, and you would hope would occur quite quickly. However, if that post-operative note isn't seen, isn't known about, or it isn't chased, you can have some complications. This can be basic things as well, such as delays and how long the patient has to stay in hospital. They were due to have a check x-ray the next day and it's missed. It doesn't happen until the day after. You can have extended stays. The other problem is additional work. If someone looks at a post-op note and does all the work associated with it, but doesn't tell anyone, the next junior doctor then comes along, goes, I'm a good junior doctor, I should really have a look at that post-operative note. Oh, look, there's some things to do, I should really try to do that. And they go, oh, someone's already done it. And then the next junior doctor comes along and does the exact same thing, and you end up having duplication of time and a real waste of time for work that's already been done. So to set a baseline, we collected some data without making any changes to see how many of the post-operative notes were chased, how much of the work was done associated with them, and how many of them were chased more than once. So these were the 14 metrics that we looked at in the post-op notes when we were looking at them when they were chased. An important one to note here that I haven't mentioned is how many were handed over. So since we now work in a shift system, the FY doctor who's covering a ward in the morning won't be the same one per se who's covering it in the afternoon, and won't be the same one who's covering overnight. So during these changes, there's always a risk that post-operative notes are lost. The person isn't aware that it still needs to be followed, it still needs to be chased. So we wanted to see how many times that was happening, and the person wasn't being told about it. So how were we at the beginning before we started changing anything or messing with anything? We missed about 6% on average every day. So considering you have a post-operative trauma list of about 15, most days there wouldn't be one missed. And it seems to be a small statistic. However, it's an important statistic because the potential complications of missing a post-operative note could be quite grim. Another thing to note, I think, and the thing we were able to reduce probably the most, was the number that were chased the most every day. So chased more than once every day was at 23%. So about a quarter of post-operative notes were being looked at by more than one junior doctor. There was a fair bit of replication of work. So if you think each post-operative note probably takes about 5 to 10 minutes to read, go on ice, and arrange investigations, there's a significant proportion of time that's being wasted there. So what did we do? Our first intervention was to have the FY sign the top of the notes. So if you chased a note, you signed in the top corner. That means I looked at this, I did the things on this note, no need to stress about it, done is done. The next thing we did is we brought the trauma list to all our handovers. The trauma list had all the patients on it at the beginning of the day. So at every handover, we would go through the trauma list. We would identify who'd been canceled, who'd been moved, who'd ended up in HDU, and which notes had been chased and which ones still hadn't been chased. So that every single note was accounted for before the next shift came on. So we tried that, and what happened? Well, we got worse. So that was great. We started to miss an increased average up to 8%. However, that's likely not very significant here because we're talking about so few individual missed notes. It's a bit hard to get in the weeds there with those numbers. However, we were able to reduce the amount of times that notes were getting double chased. So we went, oh, well, that didn't work all that well. Let's introduce some more interventions. So one of our problems was we wouldn't know when these patients would arrive back from theater. We would have them on the list. We would have a provisional order. Sometimes the order would change, and it's a bit hard to tell where in the order they are because they're often some other room operating. So you would never be quite sure when a patient would arrive back to the ward. So it made it hard to chase their notes when you didn't know where they were. So we tried to engage the charge nurses in telling us when a patient had returned to the ward with moderate success. And we also tried to use it as well to highlight some unwell patients so that their post-operative notes were chased toot sweet and that they were then handed over if the post-operative notes identified them as potentially unwell post-op. So what happened after the second intervention? A huge improvement. We got our number down to about 1% that we were missing. So we only missed one note out of the 139 that we looked at in that last section. We also got the number that we were chasing more than once down to 7%. So there was very little duplication of work. So that added 5 minutes from each person. We kept going back and back to it. We were able to keep that right down. And we were also able to reduce the amount that were missed from handover each day. So the number that had failed to be told about for the next group coming on. So this, as well as reducing complications, reducing duplication of work, this has also improved sort of your quality of work, because you knew when you were coming on, if you were only told that there were 2 notes to be chased, that you were more likely that there would actually be only 2 notes to chase. So you didn't have this sort of overwhelming sense of doom that there was a disastrous post-operative note out there somewhere in the orthopedic wards that hadn't been looked at. Another thing we were able to do, which wasn't the main goal of our project, but sort of a side goal, is we were trying to increase the speed at which post-operative notes were chased. There's no requirement per se for how quickly you should chase them, but we sort of felt that within an hour would be the best way to make it a slick service and reduce the amount of complications that could arise from a delay in chasing the post-operative note. So we set an hour as a goal, and we were able to increase it up to about 61%, how many we were able to chase within an hour. And we were quite pleased with that. So here's a bit of a summary to sort of see how we did. I think the important takeaway from this slide is that it wasn't necessarily the things that we changed in the second intervention, trying to involve the charge nurses identifying unwell patients, that really resulted in that final reduction. I think it was that people started to get better at the first intervention, so at how they handed over, at using the trauma list, at signing the top of the notes, and really began to perfect that, and that's why they improved. So, what's the point of all this? Why did we do it? Who cares? Does it matter? So, we were able to create a fairly significant change within the orthopedics department. And I think the reason we were able to do that is there was a very low barrier to entry. This didn't involve other people. It was only the FY, so you're talking about maybe 9 in the orthopedics department, depending on the group. So you had 9 people you had to involve. It also didn't increase the amount of work that they did, and if anything, decrease the amount of work that was required of them. So the trauma list is something you get at the beginning of the day already. So it's already a sheet of paper you have in your pocket. All we were asking was that people would write beside it when they chased a note. So it wasn't an increased barrier to entry. Also, I think people started to see the benefits of it once they got enrolled and working. They were able to feel the fact that they were confident post-operative notes were being chased, and that they were confident that the jobs associated with them were getting done. I think looking to other departments and other ways that we could probably implement something similar, I think how we changed how handover was occurring and how jobs were being treated and were being followed up and ensured that they weren't missed is something that could be carried over to other departments, be them surgical, be them medical. Because of how junior doctors work now within shifts, there's a lot of handovers that occur. And there's also a lot of jobs that are handed over between different groups. So there's a significant percentage of those that are lost every time. And I think the importance here is if you were able to make other handovers just as slick, then you would be able to reduce the complications that arise from these missed jobs or these jobs that are forgotten about. Perfect. So I'll hand it over, but thank you guys very much.
So my name's Tina and this is Karen, and we're here to present our QI project that we did in the emergency department when we were FY1s, supervised by Dr Bogut, who is here today. So just a bit of background for those people who aren't familiar with A&E and the observation unit. The EDOU is an 8-bedded unit in the A&E department. It's primarily managed by an FY1, a nurse. There's a consultant-led ward round in the morning with seniors popping in during the day to review patients. And patients we commonly see are patients who need observation for head injuries, overdoses, and patients who need just a bit extra attention before they're discharged home. So our role, primarily as FY1s, were to review all the patients on the ward prior to the ward round, highlight any issues that had occurred overnight, manage patients throughout the day, manage discharges, and to admit all patients to the unit. So a bit of information on this. Patients can be in the unit for under 4 hours without being formally admitted, but beyond 4 hours, they're formally admitted to the hospital. So while we were there, we found a few issues, especially with admission. So there wasn't any formal medical admission document. So this is a stark contrast to patients we see in ASRU, AMU, any patient who's actually formally admitted to a ward. And as a result, we found things were missing. So cardexes were either incomplete or completely missing. Things like past medical history was missing from patients' notes. And there wasn't really a clear summary of events prior to admission, say what happened on the other side of the department and what happened in the community. And that involved what investigations and what treatments had been done. So why was an issue? So as we all know, patient documentation is very important, specifically towards patient safety. A few examples specifically, there are quite a few drug administration errors. So patients, Parkinson's patients for example, if it wasn't documented that they had this or they needed medication, their medication was often missed, leading to delay and possible risk for increased severity of the symptoms. Patients who would often be observed for seizures, their anti-epileptic medication wasn't requested, so again, delays in that, potential risk to them. There was overall a decreased efficiency because clinicians had to go back to the very beginning, read everything, and could be quite dangerous if you're acutely needing to review a patient. And this is all supported by research into medical record keeping, and the Royal College of Physicians has guidance on what we should be doing. So our aim was, we had a hunch, we wanted to formally assess what was happening with admission documentation. So we did this doing an audit, and based on those results, we wanted to create and implement a change that was sustainable. So we looked at patients over a month at the beginning of 2017, looked at their admission documentation at 8 o'clock before the ward round, looked at when they were admitted, patient details, and whether a clerking was a success. Now our criteria for successful clerking was pretty simple. Do they have an admission summary, and do they have a cardex? So we thought there was an issue, but we didn't realize it was this significant. So out of all the admissions, so 89 admissions we'd reviewed, 63% did not have a formal clerking. We then looked at, okay, when are these patients coming in? As you can see, a significant portion were coming in during the night time, and a lot of those weren't being formally clerked in. Looking at during the day, although the numbers in total were quite small, a lot were being clerked in. So then we wondered why, and we looked at the doctors who were admitting these patients. I guess this kind of justifies the FY1 job. 20% of the time, people were being admitted, we were there, and a success rate of 89%, whereas 80% of the time there was no F1 cover, so the success rate was fairly lower. And then finally, we looked at the patients who were having the successful clerkings. So head injuries, so 50% of those who 50% of those who came in with an overdose had a successful clerking. And we wondered if the reason why this was, there was some form of performer for these patients, and we wondered if there was a link.
So just to summarise really what Tina's been saying, from our audit, we found that the majority of people were coming in overnight when we weren't there, and the majority of them weren't clerked in, but the ones that were successful were the ones that came in with overdose with a pro forma in place. And so then we decided to think about how we could potentially solve the problem. And these are the things we came up with. So we thought if we told the doctors in the department, let us know before our shift ends, so that we could clerk people in and get everything sorted before our end of shift. But that potentially wasn't as sustainable because every few months junior doctors rotate through the department, and so that may not leave a long-lasting impact. And then we thought we should raise the awareness for the need for the clerking, so Tina and I spoke at the departmental QI meeting with the senior doctors and consultants there and highlighted the problem. The other option would be to increase the FY1 presence out of hours, but as there's only 2 FY1s in the ED, we can't be there 24/7, and so the proposal we kind of ran with for our project was to create a generalised pro forma that could be used for everyone. And so we used this, we created this based on our experience in surgery, our experience in medicine, and also looking at the Royal College guidance into what should be in a pro forma. And this was the first thing we came up with. So as you can see, it's quite simple, quite basic, but has what we thought was important on it with yes/no options for ease of completion. And this is what we showed to the QI meeting in the ED. And so the general concept was praised, and it was agreed that it was something that was needed, and the extent of the not being clerked in nobody realised how big a problem it was. However, the document we showed was thought to be far too complicated and repeated quite a bit of work that had already been done in the ED, and so it was thought that this form might not be able to be fully completed as we'd have hoped, because it would have just taken too much time. And so then we came up with a new version, and so as you can see, it's a lot simpler but kept lots of the key things we wanted. So there's a prompt to do a Cardex if needed, and also bullet points for plan for admission, so that we as F1s could say, okay, this is what needs to happen, and we could do it. And Tina and I trialled this in the EDOU, and we thought it was working quite well, and got some feedback from Dr Bogax and some of the other consultants who thought that this was better than the first version, but that work still needed to be done in making it and adapting it. And that's where the idea of coming up with a universal pro forma that could work for every single admission, including paracetamol overdose, including head injury, with specifics, could work. Unfortunately, that was when our time in the ED was up, and so the job kind of handed over to Annie and Heather, who were the FY1s that replaced us, along with Dr Bogax, who combined all these ideas to create this. So as you can see, it's got many of the same aspects that we had first wanted and contained in the pro forma, but also has the paracetamol nomogram for overdose and head injury documentation that can make things easier and hopefully improve the job. And so overall, we audited it to find out what the problem was. We identified the problem and came up with an admission tool which could be used to solve the problem. It's had positive feedback from staff, and there's been no requests to amend it at present, and so it's the one that's currently in full use. And on a more personal level, Tina and I have gained in ourselves in our understanding of QI and PDSA cycles, and it's been quite nice to know that even just as F1s and now F2s, we've been able to make a difference that's lasted, and you don't need to be a consultant to do things. Thanks for listening.
Good afternoon, everybody. My name is Gianluca. This is Neil. I'll be talking about a quality improvement project we did on the surgical floor under the guidance of Vicky right here. The aim of the quality improvement project was to try to address the issue we identified between Ward 7, which is the Acute Surgical Receiving Unit, and Ward 8 when it came to handover of patients who were admitted to us, would receive initial treatment, and then very quickly moved over because of the high turnaround of patients. We realized during our time there that quite often patients would be randomly moved, especially after the morning ward round, and then would magically appear on Ward 8, where the foundation doctors would have absolutely no idea who the patient is and what was going on, just because there was no formal handover process at the time. We wanted to quantify this. We wanted to see whether this was just us being inattentive or whether other foundation doctors who worked on the wards felt the same way. So we sent out a very brief questionnaire to 26 foundation doctors who basically worked on the surgical floor for the previous 6 months. So we had a mix of experienced FY1s who had been there for the whole block 4 whole months, and FY1s who had perhaps just started or were midway through their rotation. And what we wanted to do is to look into 2 main things. A, was there a formal handover at any point during these 6 months? And B, if there wasn't, what was commonly missed? What were we missing? What were the patients, in what aspects of patient care was being compromised? So the first question, how many times? We got 15 respondents out of the 26, and 60% of those said that none of them had ever received a formal handover when working on Ward 8. Some of them, so 33.3%, said they had, but most of the time this was an informal process where the Ward 7 doctor would go through and have a very brief chat with their counterparts on Ward 8. One person said that it's 5 to 10 times, but they must have had a good team during that time. I don't know what happened there. In terms of jobs that were missed, we found that almost everyone felt that the most commonly missed, everyone actually, the most commonly missed jobs were antibiotic levels. So someone would be started on Mox Method Gent for biliary sepsis or whatever, transfer through because they are stable, but then wouldn't have their Gent levels done. And then we have a whole situation where we need to do 24-hour levels and dosing is missed and all this stuff here. Blood test requests, medication doses, cardexes not being filled in properly, medrecs not being completed. Paperwork is occasionally missed. This mainly would relate to cardexes, AWIs, DNA CPR forms. Requests from radiology, so MR-CP requests in particular, CT scan requests sometimes. Referrals, especially if we're talking about a patient with an acute abdomen who would be a urological patient. General surgeons would say refer to urology, but that never happens. So the patient's just sitting on the ward for a day with nothing going on. Senior reviews, occasionally, not very common, thankfully. Endoscopy requests, mainly because they are paper requests, and very rarely troponin level as well. So our aim was to try and implement an effective and an efficient handover process for these patients. Something that would be easy to complete and that wouldn't take much time. That's what we tried to do, a concise handover sheet, 1 page, which integrated both medical and nursing bits in patient care. We wanted it to be easy to fill, because we don't like time-consuming tasks. And finally, when put in the patient notes, we want it to be easy to find. So when the patient is through to the next ward, we know exactly to look for the pink sheet with all the handover information on it. This is the handover sheet we came up with. I'll zoom in on the jobs, but basically very basic information: patient name and KI number, the date and the time of transfer, presenting complaint and the provisional diagnosis, because obviously most patients we might not be certain what was going on. We would be treating empirically initially. The list of outstanding jobs, which is right there, and then obviously at the bottom, name, bleep number, signature of the doctor sending the patient through, just in case there were any questions that would arise that would need to be clarified. The outstanding jobs, obviously, as we said, it's a tick box exercise, so we tried to divide it into the things that were most commonly missed: antibiotics, Gent level, Vanc level at the very top, because we found that those were very commonly missed, as demonstrated in the previous slides, investigations, and so on. We did this over a number of months, and we used the PDSA cycles as a standard for most quality improvement projects. So we had 4 PDSA cycles. First one was to create and to introduce the tool. We then started trialing the handover sheet. We started with a 1-day trial, where Neil and myself would go through and prompt medical staff, reminding them to fill in the form. We also had guidance, printed guidance on the walls in Ward 7 and Ward 8, reminding everyone, don't forget the handover sheet. That went pretty well. We did some minor changes to the handover sheet, and then we tried again a 5-day trial until ultimately on the 4th cycle we went for a 2 whole week trial And we also tried to include out of hours, which was a bit more tricky due to lower staffing levels. In terms of results, so what we did to collect these results, we sent out another questionnaire. That was one way of doing it. The other thing we did is we kept all the handover sheets and went through them one by one to see A, completion rate, and B, what was still being missed or what was still being left out. And after 4 months, we found that only 20%, so 3 out of 17 respondents at the time, had never received a handover. And this probably happened at the very start of the handover process when the form was still being introduced. 15 or 90%, so we had 17, this is a question that was answered by 17, so 90%, 15 of them, felt that the introduction of the handover tool made the process smoother. And 14 respondents felt that it had improved patient safety because we found that less tasks are being missed. As evidenced by this slide over here, we found that, for example, missed antibiotic levels had gone down by half. 50% of the, I believe, 85 or 88 handover sheets that had gone through over these 4 months. So 50% of those show that antibiotics levels were still being missed, but that was a significant improvement from our first trial. And a similar pattern obviously follows for the rest of the jobs that we had included on our handover sheet, except for whatever reason, endoscopy requests. And I still don't think we have an explanation for this. I still blame it on the paper forms, to be entirely honest. Well, after 4 months, we found that the handover sheet is a simple but an effective tool that can provide a formal and structured handover, especially for non-urgent tasks. We still found that urgent tasks, things that needed done there and then or immediately after transfer, were best either phoned through or walked through by the FYs on Ward 7. We found that obviously patient safety, because of the lower number of missed tasks, had been increased. And we found that there is more communication between Ward 7 and 8 simply by the introduction of a piece of paper, which is amazing, I think. Challenges still exist, and this is what we wanted to focus our future work on. We found that often there was a breakdown in communication between the nurses, the nursing staff, and the medical staff, mainly because the nurses would want to move patients through as quickly as possible, which is very understandable because Ward 7 is very often pressed for beds, which would not allow the medical staff to get everything sorted in time. And we also found that because of the high turnaround and the pressures on the medical team on Ward 7, it was often just forgotten. The handover sheet would be forgotten. So we're working on putting up visual reminders, big massive posters to remind the foundation doctors about the handover sheets, or maybe also introducing other measures, sticking stickers into the folders where junior doctors would write on a daily basis, remember your handover sheet. And obviously Neil and I are both moving on, CMT and CST respectively, so we will be now looking for new foundation doctors to carry on working on this project for us once we're gone. Don't know if you wanted to add anything.
Yeah, no, I think it was a project mainly focused. I think handover, often we think about formal handovers at beginning and end of days. We forget about the amount of intra-hospital, inter-hospital transfers that happen every day, and the little things that seem trivial but can have a massive impact. And we really wanted to try and work with our nursing colleagues because they have such a massive role and control in so many aspects of patient care and bed flow. So hopefully this was an aspect that, when we engage with the nurses and work well with them, we actually managed to improve the system. So I hope it's a good example of something involving other members of the team. So yeah, thanks very much. That's it.
My name is Fraser, I'm one of the FY2s. I'm going to go through a QI project that we did as an FY1 and is still going at the moment in the ophthalmology department. So a problem was brought to our attention from our primary care physicians who said that they tend to feel a bit uncomfortable when they try to change a branded product, particularly in ophthalmology, to a non-branded product. There's a lot of different formulations for ophthalmic drugs. Some have preservatives and some don't have preservatives, some are single use, some aren't single use, and they said that you kind of get lost in the thing. And they found it quite difficult, and they found that actually they were concerned that they were spending more money than they needed to. So they spoke to Dr. Cobb, who's one of the glaucoma consultants, and she came and grabbed me, and we started a project on it. And the conclusions we came to before we even started was that this is something that is probably a procedural problem more so than anything else. So the study question was how often are branded and non-branded medications prescribed during a 1-month glaucoma clinic for one consultant? And can the cost of that prescription be reduced? So we took Dr. Cobb's glaucoma clinic. This is November 2016, so it's before we thought about doing the project, if that makes sense, to try and reduce biases. We had 188 patients in a 1-month period. And what we were looking for particularly was what was prescribed, who prescribed it. And we recorded a regimen, though that's not really relevant for this as such, so it's not really commented on for the rest of it. And then we looked to see if it was stocked, how much it cost the hospital, and if it wasn't stocked, how much roughly it cost from the BNF, which we got our pharmacy colleagues involved for. So the exclusion criteria, there are 5 patients who didn't have a clinic letter. And if there was no clinic letter, we kind of looked at what the GP would see from the previous clinic letter and used that as data. 41 had no medication, and 4 were not a glaucoma patient, but were just added to the list for ease. Most of these patients were reviews more so than changes to medication. So we had 138 prescriptions, and most of them, well, they kind of split down the middle mostly. What was quite interesting was the breakdown of who was prescribing what. Only 1 prescription from the specialist, and they got 100%, so they were doing well. Everyone else, the more junior you got, tends to be the more likely you were to prescribe a generic. So we then put that in and we worked out what the possible savings were. So from a total cost of about £1,200 for one consultant for 1 month's worth of clinics, we found there was about £174 worth of savings. This is limited because a lot of the drugs that are prescribed are formulations which have multiple drugs within them, and it's actually very difficult to prescribe those individually, or there's no equivalent generic. So we found there's a potential saving of about 11.912%, and that was just for one bottle, if that makes sense. It doesn't really take into account how quickly that bottle disappears, or the repeat prescription. Patients are on these drugs basically until the day they die, so it tends to be very expensive, and these become compounding errors. So first change we did is we had a little discussion with particularly the registrars at their weekly meeting, and we discussed everything, and we talked through how expensive things were and how we could save money. Interestingly, we ended up having an unintentional control because some of the prescribers, the optometrists, weren't there. So we then actually had an unofficial control, which was quite interesting from that point of view. So we enforced this with generic prescribing, with a little card which had various things and the cost, and generic to proprietary transformations on it, which looked a bit like that. And most of our drugs, actually, we don't really have a generic transfer, but for some of them we do. Particularly, for example, Zatalan's very expensive, and actually there's a huge saving cost per one of those. And you go through one of those in 30 days, if not shorter. And the final change, glaucoma clinic is a bit mad. There's lots of patients, it's very busy. So the registrars wanted something that was automatic, and they didn't add to their workload, kind of what some of my colleagues have been talking about. You need to make it as efficient as possible, otherwise it just makes it more likely that you're not going to get your lunch. So we wanted to put an automatic step in. So what we did is we discussed it with the GPs, and the GP said that if there was a letter, and even a short line at the end of all their discharge scripts that say we endorse generic substitution, unless we specifically say otherwise, they were happy. So we put that in. And this brings me on to unintentional changes. So we added this one line essentially to the bottom of every dayside discharge letter. So if Mr. Scully there had a lap chole patient and he discharged them on no medication, at the end of the signature there was the Department of Ophthalmology supports the use of generic eye drops unless the brand agent is specifically questioned by a particular patient, which caused problems. So for about 2 days, you can actually find them now. If you go through Clinical Portal, you can find the odd one of them. It's quite funny. So yeah, that was me if anyone received interesting and quizzical looks from other people. So that's been removed. There's one where 0 wasn't a 0, where 1 was. And unintentional changes are always interesting. So the current situation, I think we've re-audited this now, I 5 or 6 times. We're putting it out to various other various other aspects within the ophthalmology outpatient clinic. Mostly these are being handed over to medical students who want to add it to their portfolio. And because I did it with glaucoma, one of my friends is doing it with vitreoretinal, for example, it sounds like a different project. So when you actually present it at your interviews, it looks like you've made your own thing up, but actually it's just copy and paste work. The two limitations to this is it assumes there's no primary care generic switching. Now we actually have some evidence to suggest this is true, because the primary care physicians were looking at their own prescriptions which were coming out of the pharmacies and being concerned about it. And it doesn't take into account the speed of the eye drop being used up. So it doesn't really take into account kind of the cost per patient for their lifetime and how much that actually saves. So the conclusions that we drew was the best improvements are those that do not add any steps to a process unless they're absolutely required. And in brackets, just make sure if you are going to give it to someone that you give them very specific instructions, otherwise you might end up getting something you didn't expect. And very small changes can yield large improvements. We're sitting at the moment about somewhere between 8.5 and 9% on H consultants each month last. So it's a reasonable amount of saved money. Didn't realise I had a reference page, but any questions?
Desk instead. I don't know if that's going to work.
No, back to the microphone.
Oh, back to the microphone. All right. I see. That's fine. That's fine. Hello, my name is Marius. I'm an F2 currently working in psychiatry of old age, but this project started on a lazy Monday morning when I was an F1 in orthopaedics and PRI. I was there clerking in patients coming in for elective orthopaedic operations, and there were 2 for which I had been told I needed to do group and save samples. So you will probably all be familiar with what that means, but I am going to give a bit of background because I didn't know who was going to be here today. Now, these 2 patients I could see on the computer system had already had samples taken on the Friday before this Monday. And I thought, oh, I might not need to do one. But because I thought I would do my job properly, I contacted BTS and asked, are these samples still valid? And I was told, no, you will need to take a new one. My first thought was, and my second thought was, okay, why did this happen? So I phoned the guy up again and I said, actually, can you tell me what makes the difference between a sample that's valid for just 3 days and one that's valid a little longer? And he said, well, it all comes down to this one thing. It's a tick box on the form for the group and save sample. If the person taking the sample has not ticked a box asking whether or not a patient has had a blood transfusion or been pregnant in the last 3 months, the sample will default to being a 3-day sample. Now there's a reason for that, and I'll come on to that. So this was where that started. I thought, right, how often does this happen that I have to now go and repeat a sample that could have been valid if somebody had asked the question and ticked this box? In fact, these samples cost about £20 to £25 per sample to analyse because of the nature of them. And I thought that's got to be expensive in the long run if this happens really often. So that was the basis of this project. Right, that's what it looks like, and I have made a wee red square around the tick box in question. Now, that's all it takes. A tick in that box, if you can answer, no, this patient's not been transfused in the last 3 months, and no, they have not been pregnant, makes it valid for 7 days rather than 3. So the samples that were taken that Friday before the Monday would not have been taken in vain. Right, this is the normal process. You identify a patient that has a predicted risk of significant possible blood loss. You will want to take a sample, then a second sample, and once those criteria are in, blood components can be issued. Now, the difference between the first and the second sample really is in why we take them, not in what we do to them so much. Any group and save sample is analysed for blood group and any present antibodies. The first one acts as a reference so that we know what blood group a patient has, and the second one really is there because it's less easy to take a wrong sample from the same patient, a wrong sample without noticing if you have something to compare to already. Like, if I went and I took one sample from a patient without a repeat, I wouldn't have had the chance to discover that I had gone to the wrong person in the first place. So that's why that's the main reason why we do 2 samples, is to really double check we've got the right person. And also, other reasons are that over time, patients' antibodies can change. If you are given blood transfusions from another patient that has antibodies, or antigens that are different to your own, you will develop antibodies over time. If you are pregnant and your child has a different antigen on its red blood cells, it will cause an alloimmunization in you. So you can develop different antibodies over time. You can even, if you have a bone marrow transplant, develop another blood group. So there are reasons why we repeat this. Now, the way I collected data on this, to answer this question of how often do we miss this tick box, I phoned up BTS in Perth. I said, look, I've got this problem. What do you think? Should we look into this? And they were really helpful. They sent me 2 months worth of data where they scanned all of these forms that you just saw that had been filled in the pre-assessment clinic. So only in the pre-assessment clinic. I thought that's a good place to start. That's where this kind of happened. The pre-assessment clinic is a guideline-driven place. So any kind of change we want to make should be fairly straightforward. It's not that we need loads and loads of people to do this with. It's a small group. So they sent me loads and loads of forms, and it turned out to be way too much data. So I looked at just 3 days worth, and that equates to 56 samples. And they were taken from the 1st to the 3rd of March in 2017. Now, of those samples, 46 were first samples, i.e. they had written on this form that this was the first sample we have for this patient, and 10 of them had written on them second sample. So this would be the last sample that this patient had taken before they went into surgery and possibly needed to get blood products. Now, I found straight away that of all the samples I looked at, the boxes had been ticked every single time. I thought, right, okay, well that's good. I probably just stumbled across something a little bit out of the ordinary, an outlier, and I've just been unlucky and had to repeat these 2 samples that Monday morning. But something started to kind of pop out as I was looking at these numbers. So was the audit over? No, definitely not. It turned out that of all the samples we had labelled as first samples, we had historical references on ICE for about 1/3 of them. Only 66% were true first samples. Now, I'm going to come back to a little bit of documentation about why that's important, but it basically means we have a reference, we know the blood group, we know the antibody profile of 1/3 of our patients, and yet that same 1/3 we go and we repeat a first sample for. That's £20 to £25 per person each time we do that. And in 1/3 of cases, it's unnecessary because we have that historical reference already available to us on ICE. So this equated to an average of 6 potentially unnecessary samples per working day. There are 261 working days a week. That's when pre-assessment clinics open. They don't really run on the weekend in Perth, or they didn't at the time. Using a conservative estimate of £20 per sample, that is a lot of money every year. That is just over £30,000 for first samples that probably are not needed. Right. Second, this was the guideline I mentioned. So the British Society for Haematology have actually put out a document that answers exactly this question of, is a prior sample, a historical reference sample, valid? How long can it be valid for? What's required? What circumstances are necessary for that to be a reliable, valid reference as a group and safe sample? It's a really long document, but in short, and of course this doesn't go into all the intricate details, but in short, if the analysis, the storage and the transfer of all that information has been done by a machine and then put into our computer system, they call it a LIMS, a Laboratory Information Management System. If that's all been done without any human intervention, then that sample is valid as a historical reference. There is no mention of how long that can be true for. Whether that's a good thing or not, that is something we can discuss at the end. But effectively, at the moment, the guidelines are on our side. So, second samples, something else popped out. Of all the second samples that are taken, we know already from our conversation with BTS that Monday morning, the longest they can be valid is 7 days. Now I compared the date of second sampling to the date of operation, and it turned out that about a third, or 30%, of these samples were taken more than a week in advance of the day of surgery. That means that on the day of surgery, that sample is no longer valid. I'm going to need to take a new one anyway. So there were fewer second samples, and so the money we can save here isn't quite as big, but it still amounts to about £5,000 in Perth's pre-assessment clinic alone per year. Right. What do I not know? I don't know that the cost of a group and save sample is exactly £20 in the lab here in NHS Tayside. Those are numbers from Glasgow and Aberdeen. But all the numbers I've been able to find are in that ballpark. So I don't have a lot of days worth of data. I've only looked at 3 days. I am assuming, in presenting you these numbers, these estimates, that those 3 days of activity are representative of the entire year. That might not be. We all know there are times when things are crazy and when things are a lull. I don't know where we were in that March. So, now, I've put dilemma of acceptable time from first to second sample, and this feeds back into what I said about the validity of a first sample and how long that can be true for. And the British Society for Haematology have this guideline that don't mention anything about time, but because of course, I'm running short on time, I can tell. Sorry about that. Because changes can happen over time. The longer you leave it between the first and the second sample, the longer you leave a chance for something to occur, something that changes the antibody profile. Now, I will put this to you. At the moment, our system is no better at detecting that. We may have pre-assessment clinics that mean we take a sample 6 months in advance, but loads can happen in that time. And also, we have currently a system that allows knife to skin before a second sample has actually been analysed in the transfusion service. So I don't think that these changes will mean any less safety. They will mean a few changes in the pre-assessment clinic, checking on ice whether someone has a previous sample, and it will allow us to save a whole lot of money. It's not going to be something that patient feels, but it might be a bit of oil for the machine that is NHS Tayside. I heard it's rusty. Thank you very much. I was going to tell you some more, but anyway.
I want to move on to the important part now, and it's the voting. So what I would like to make sure is that everybody in the audience has a handset. You've got handsets? Everybody? You're not allowed to vote alone. What we want you to vote, is it open, voting open? Which presentation you thought was either most interesting or the best out. So there's voting A to E, so press who you want. So we've got A, post-operative notes in orthopaedic, that was Matt, check-in obs, and the obs unit in ED was Tina and Karen, handover in surgery, Gianluca and Neil, cost of glaucoma, Fraser, and group and save, at the end, Marius. So voting starts now. Okay. Ta-da! Results.
Do you have a prize?
We do. We do have a prize. It's a prize worth nothing. So we have certificates. Oh, sorry. Yes, we do have a prize, and the prize is for Matthew. Would like to come forward. So Matthew's project on looking at the post-operative notes in orthopaedics.
Perfect, thank
That's
you.
courtesy of the DME.
Wow, this is a lot of money.
Actually, do you know, I thought all the presentations were absolutely superb. I thought the quality was excellent. I think there's an awful lot of work that's gone in, and what I was really impressed with is actually these are real meaningful projects that have been done in the wards and in the units, and I think it's really, really encouraging and exciting that you're actually doing all this work. This is just the tip of the iceberg. There's a lot of projects being done. In NHS Tayside by our foundation doctors, and these are the ones who decided they wanted to come and present today, but I think we should do a lot more of this because I think this is fantastic. I don't know there's not many people here, but I don't know what your thoughts are on that. Do you think this is something that we should maybe do on a more regular basis and get the units to support it? I think it's great. This is just the tip of the iceberg. So we have some certificates for portfolios. Okay. So do you want to come and get your certificates, or I just hand them out? I'll just hand them out. Is that all right? Can I walk away from the microphone now? Yes. Yeah.
And I'm meant to be doing an RP now.
Okay. Right. You better go to your RP. Okay. Thank you very much, everyone. Thanks for coming. Okay. Right.